I would just like to say a few words about the most recent study, which is the study that I've been involved in using this technology. It isn't a long presentation. I'm aware that certainly in the UK, this is the first evening of the next stage of lockdown. So it's a case for great celebration here in the UK. But thank you for giving me this chance to speak. So I'm going to start at the beginning, if you will. And that is just by reminding people why there's the interest in developing this new technology. And here on the left-hand side of the slide, you see that very familiar definition of osteoporosis. So it's characterized by low bone mass and deterioration of bone tissue, leading to increased bone fragility and susceptibility to fracture. And of course, it's fracture that's the devastating consequence, and Paul's already alluded to that. But really, any technology that we look to develop would ideally measure bone density or bone health, bone quality, bone strength at the common sites of fracture. And particularly where we tend to be interested in the spine and the hip. There are good epidemiological data now that say that actually other fractures are also very important, but traditionally we've been very interested in technologies that can look particularly at the spine and the hip. And really, whatever technology we apply, what we're trying to do is two things when we think about the management, the public health management of osteoporosis. So on the right-hand side of this slide, you can see that actually, yes, of course, from a public health standpoint, we're very interested in improving everyone's bone health. So we would like to shift the bone density of the whole population to the right. But really focusing on the left-hand panel here, and that's obviously really what we're talking about today, what we want to do is identify those individuals who have poor bone health, because those are the cohort of patients that actually we're going to target therapies to. And we've already heard that actually nationally and internationally we miss a lot of these vulnerable individuals. So it's important that we find ways to actually capture these people. So when we think about osteoporosis, and you've already seen a slide a little bit like this evening, really we have a double hit, if you like. You know, we talk a lot about bone density, and of course bone density is reduced in osteoporosis, but we're also interested in bone quality, because we know that actually both those things will actually impact bone strength, and bone strength is what ultimately determines fracture risk. So traditionally, of course, we've used DEXA. DEXA is, you know, an excellent tool. It's, you know, very well validated. It's very widely understood and used. But we also have this slight anomaly, if you like, whereby we do see people fracture at relatively good scores on DEXA scanning. And that's because we recognize that actually bone density, which is the thing that we're measuring with DEXA, isn't the whole big picture. There are other aspects of bone quality and bone strength that we're interested to capture. And of course, heel ultrasound was something that there was a lot of interest in as a possible way of actually looking at some of those other aspects of bone quality. So I suspect a lot of the people on the call will be very familiar with heel ultrasound, so I'm not going to dwell on it. But the measurements that it gives us tells us something not only about bone density, but also bone stiffness and structure. And that's interesting and that's important. And of course, ultrasound systems are attractive because they're portable, there's no radiation, the technology costs less than a DEXA scanner. But we also have issues. Heel ultrasound is typically less specific than DEXA at picking up individuals for fracture, and it looks like predictive capacity tends to wane with time. And as you can see from the picture on the slide, you know, calcaneal, you know, heel ultrasound is the site that we would normally used for this technology. And I've already mentioned, ideally, we'd be looking at other sites. So, I mean, just before I get on to obviously the main topic of this evening, I just wanted to say a few words about QCT as well. So QCT is an X-ray based technique, so it does have quite a high radiation dose. But I mention it because it's another tool that actually looks at bone strength and gives us the most beautiful images of different types of bone when we actually do these scans. So we can look at cortical and cancellous bone, and it can give us imaging in 3D. I'm in awe of the pictures that it gives us, but as a sort of a practical technique going forward for widespread clinical use, it doesn't seem realistic. You know, the scanners are very expensive. There are very few available. We're fortunate to have one in Southampton. We use it a lot in our research, but it isn't a clinical tool. And as I say, the radiation dose is quite high. But here you see a picture of the scanner. So with all that in mind, I'm just going to say a few words about this study, which, as I've said, I was involved in Southampton. That is, I suppose, is the next step in the R.E.M.S story. So this is a publication that came out just a few months ago in Bone that talks about the findings of a multi-centre European study that uses R.E.M.S. So I won't dwell on this slide because you've already heard a lot about the technology and how it works. But I draw you just to the final point on this slide, really, and that is that actually a lot of the previous work that's been done looking to validate this technology has looked at specific age ranges and has been focused specifically in Italy. So the aim of this particular study was to actually consider the diagnostic accuracy of R.E.M.S technology with respect to DEXA in a large European female population covering a very wide age range. So it's different from the previous work because it's drawn in patients from other European centres, and it's also considered a much wider age range than has been studied previously. And then the second aim of this particular study was to compare R.E.M.S and DEXA in the identification of subjects with previous osteoporotic fracture. So specifically to identify those individuals who had had fractures before and to look at the performance of R.E.M.S with regard to DEXA in that regard. So just a few details about the methods. So you can see that the number of people enrolled to this study was a little over 4,000. It was 4,307 Caucasian women aged between 30 and 90. So as I said, a wider range than has been studied previously. And you can see the number of scans that were obtained here. So 4,245 lumbar spine scans and 4,271 femoral scans. And you can see on the left-hand panel here, the sites, the recruiting sites. So here in the UK, it was represented by Southampton. So I won't dwell on the technology, you're very familiar with this, but just to say, certainly the way it worked in Southampton was that anyone who had been referred by their clinician for a DEXA scan was asked if they would be willing to enter the study, to also have an ultrasound performed at the same visit. And a very high proportion of our patients certainly were very happy to do that. So, in terms of quality control, obviously this is an important aspect. 2 experienced operators were checked all the medical reports and the R.E.M.S data sets, and they did that independently and in a double-blind manner, and ISCD guidelines were followed. So where there did seem to be issues, they were typically associated with the things that I put on this slide. So wrong settings of acquisition parameters, or not completely following the software indications or the user guide. And I'll show you in a couple of slides just the impact that had on the numbers. But broadly speaking, certainly the feedback from our technicians in Southampton was that the scans were easy to do, and they enjoyed doing the scans. So this is a really dry and boring slide for about 6 o'clock on a Monday night. So I apologise in advance, but just a slide really to summarise the statistical approach to how the results were analysed. And I'm going to show you some slides about this in a minute. I'm going to show you some slides that show the Pearson correlation coefficient between the DEXA and REMS. I'm going to show you some Bland-Altman plots. We looked at diagnostic concordance between the two, but by Cohen's kappa statistic, and DEXA was used as the gold standard. I'll also show you the positive and negative predictive values of REMS for the different age groups. And then finally, we did look at capability of T-score values to discriminate patients with a previous osteoporotic fracture by looking at area under curves of the ROC curves for DEXA and REMS measured T-scores. So I'm going to show you some graphs that really summarise all those results in just a second. So I mentioned that obviously there was an element of data cleaning. I told you that 4,307 women were enrolled, and here you can see the number of usable scans. So 3,464 lumbar spine and 3,608 femoral scans. So here as a postscript to the slide just underneath, you can see the reasons why those numbers dropped. So there are about 10% erroneous DEXA reports, and 7.6 and 8.8% REMS scans were erroneous for femoral neck and lumbar spine. But broadly, actually, all the recruiting centres recruited very similar numbers of individuals. So just a slide showing you the typical characteristics of the women that participated in this study. You can see that actually the results are very similar for the femoral neck in the top panel and lumbar spine in the bottom. And broadly speaking, the median age was about 60 years, BMI 24.5, very similar actually for the two scans. And I mentioned earlier that a particular area of interest was looking at performance of REMS in identifying fragility fracture, to see whether there were differences in people who had sustained, were known to have sustained a previous fracture. So this slide just reports a number of people in whom there was a history of fracture when they attended for their scans. So there were 283 women out of the 4,245 lumbar spine scans who had had a prior fracture, and 300 women reported a prior fracture who had their femoral scan. So just turning to the results. So here you can see two panels on this slide. The first, this is the correlation between DEXA and REMS, and you can see that actually there's very good correlation. At the femoral site, the R was actually 0.93 here. And turning to the right, this is the Bland-Altman plot that gives you a sense of sort of the agreement between DEXA and REMS. And what you're looking for is a nice tight cluster around this line here. So you can see that actually, yes, we're not seeing random scatter. Actually, we're seeing a nice cluster around that line, suggesting that actually the two are performing in a very similar way. So this is at the hip, And actually the scan at the spine is very similar. So again, the same format. So this is the correlation between DEXA and REMS. And again, here the R was 0.9. And again, if you look at the Bland-Altman plot, again, you can see there's this nice clustering around the line here, suggesting that actually we're seeing good agreement. So I mentioned that sensitivity, specificity, positive predictive value, and negative predictive value were all calculated for this technology. And this slide just shows you the performance by the different age bands, because of course, one of the things that they were particularly interested to do was to see actually whether this was a technology that actually performed well across all ages. And actually, I start by just pointing out the number of individuals in each of the groups. So you can see that actually there are a lot of women performed in this kind of age group. And then what you can see is that actually sensitivity is very good actually in the whole group at about between just under 86 and up to 91%. The specificity ranged from 87.6 up to 99.8. And actually looking at the positive predictive value, you can see this went from 78.3 up to 94.7. Negative predictive value was sitting nicely in the 90s. So in terms of the performance, it seemed to do well in terms of picking up people deemed to be osteoporotic according to DEXA's gold standard. So just a few words about what I'm going to call the real life scenario. You know, there might be people thinking, well, okay, but if you've cleaned out all these other scans, you know, what impact does that have? And in a real life scenario, that might be difficult. So actually, when you look at the whole real life scenario, actually, we don't see much change to the figure suggesting that actually the technology was performing well. Just a few words about fractures. So I mentioned that one of the aims of the study was to look at performance in discriminating between people who were fractured and didn't have a history of fracture. So what you have here is that as a box and whisper plot. So you've got here DEXA, and here on the right-hand panel, REMS, and this is at the hip, and this is at the spine. And what you can see is that for DEXA, as you would expect, those women who reported a previous osteoporotic fracture had lower bone density scores, but you can see that actually you see exactly the same pattern, if anything more pronounced, for REMS at the hip. And then when we look at the spine, again, you can see that DEXA performs as you might expect, or as you would certainly hope it would expect, with low values for women with a history of fracture, but REMS actually does the same, and again, if anything more so. So what are the limitations? You know, what's missing from this data set? Well, obviously, all the results that I've shown you are for female Caucasian patients, and it will be very nice to see data for men, and I believe those data are coming. As I say, you know, this particular data set was restricted to Caucasians, and it's a cross-sectional validation study. It doesn't include a sort of a longitudinal follow-up aspect. What for me are the areas that potentially most interest me as a clinician? Well, the first group I would say, you know, women for whom you don't want to use a technique that uses ionizing radiation. You know, obviously pregnant women is probably, you know, one of the most extreme examples of that, but there are others. And I suppose, you know, the other particular interest for me as a clinician who sees and counsels quite a lot of women who have quite significant lumbar spine osteoarthritis, but who may also have had, for example, hip replacements. So we can't look at the hip. It would be really exciting to have a technology that actually would give us would give us information at the spine that we could be more confident of, given the problems that we currently have with DEXA and interpretation if someone has a lot of osteoarthritis. So with that, I'm going to leave you with this slide. It's been a very interesting study to be involved in, and I look forward to the discussions in a little while. Thank you.